All right, so if you just came on, you did not miss anything. This is what's in the pharynx. So the nasal pharynx, eustachian tube, and pharyngeal tonsil. The oral pharynx goes all the way down to the hyoid bone. And then you know where your soft palate is, you can kind of feel that with your tongue, right? And then the fosses are where they open, where it opens to the oral cavity. And then the laryngopharynx, that just opens into the larynx and the trachea. So again, nothing that I'm gonna ask you on the next. It's an exam, right? Nothing that I'm gonna ask you on the exam, just to kind of give you an idea. You see some other things in here. Um, Again, this is the uvula, and when you swallow, this thing's gonna come up and block the nasal passage. And actually, this right here, the epiglottis, this is the very top of the larynx. So this thing's the larynx right here. The epiglottis is going to come down here and close off the trachea so that the food can go down the esophagus back here. There's these things called in your nose called conchae or turbinates. They're they're just like, a conchae, like a conch, it's like roundish, like that shell. And that's kind of what they call it. It's just to trap moisture, to make it more moist, keep the moisture up in your nose. You don't want that thing dried out. Um, yeah, let me move on, get a different shot. Here's the larynx. So your hyoid bone, the only bone that doesn't articulate with another bone. The thyroid cartilage, which is your Adam's apple. I need to touch my larynx whenever I talk about it. It's like weird. Um, Adam's apple is your thyroid cartilage, and then the next cartilage underneath is cricoid cartilage, and then this right here is a combination cricothyroid ligament. It's in between the thyroid cartilage and the cricoid cartilage, cricothyroid ligament. And then you have the trachea. This is kind of a posterior view. There's your epiglottis at the top here. Remember, that's going to fold over and that's going to block access to the trachea when you're swallowing. And of course, you can see your thyroid gland, you can see the parathyroid glands. That kind of brings us back to the first chapter we talked about, the endocrine system. Um, Notice that look at the trachea here. There's about 16 to 20 of these rings. It's called hyaline cartilage. These cartilage rings, and you could feel them on your trachea. They don't go all the way around, right? They're more shaped like a C, because behind the trachea, right behind the trachea, is the esophagus, right? So this is coming in from like a sagittal view. Here's the esophagus, and so the rings, like here's like a little cross section. They don't ring all the way around, right? The back of it is kind of open because that leaves room for the esophagus to open up a little bit. But that's one view of your larynx. There's a side view, a sagittal view of your larynx. Nothing to see. Here's a view looking either anterior or posteriorly. And I don't know. I'm going to assume it's looking down. Yeah. Yeah. It's looking down, right? Because there's your tongue. All right. So you're looking down. You can see the rings of the trachea a little bit. And then you see like these two folds, right? This white one, that's a fold. And then here is another fold, right? So they call them vocal folds or vocal cords, the white part, and then the other part is called ventricular folds. So the ventricular folds, if you were to take like a deep breath and hold it in, like someone was going to hit you in the stomach or something, and you're holding your breath, you're holding it all in, that's what the ventricular folds do. The vocal folds, obviously they create sound. So if you kind of look at it from over here on the left, there's two sets of muscles that control whether those ventricular folds, I mean those vocal folds, come together or go apart. As they get closer together, it makes a higher pitch sound, and as they move further apart, it makes a lower pitch sound. And they're controlled by um, mostly by two sets of muscles, which they're showing you here. They're both called cricoarytenoid muscles, right? So you've got these posterior ones and then you've got lateral ones. And depending on which of them is contracting, that's going to move the vocal folds closer together or further apart. We haven't really gotten on physiology yet. We're still kind of looking at the anatomy. Um, there's a there's just a section of a trachea with the esophagus behind it. Again, we're looking down. I think we're looking from superior to inferior. Um, here's the hyaline cartilage in yellow. It doesn't go all the way around. There's the esophagus. So the esophagus is usually rather flat looking until food goes through it. All right, so let's look at the trachea. It's about an inch in diameter, and it's got 4 layers to it. The first layer of the trachea we call the mucosa. The first layer of a lot of tissue, a lot of tubes, is called the mucosa. So also, like the stomach, your intestine, your esophagus, we use the same word mucosa. I could use it for the inside, like the lining of my cheek. That's the mucosa. So mucosa is often used to mean the lining. Of course, we know that that tissue is epithelial tissue, but mucosa is a common way to refer to it. So it's the only place in your body that you find this pseudostratified epithelial tissue. And I don't really care about whether it's pseudostratified or not. The important thing that I care about here was the fact that it's ciliated. So there is some ciliated tissue in there, meaning that the cells have little finger-like projections, little hairs. I think we talked about this, how they kind of push the dust and stuff up far enough so that you can cough it out. When you're clearing your throat, that's often because of the cilia on your mucosa layer. So that's the most, like the deepest, most internal layer of your trachea. And then you've got a layer underneath of connective tissue, which we call the submucosa. And that just has some mucus glands in it to secrete the mucus that will go into the mucosal layer. And you've got a third layer. That was what you saw in yellow. Hyaline cartilage. And you really can't see the layers here, but I mean, obviously, the mucosa is going to be this lining. This is like the lining of the trachea. And there's like a little bit of a red in here you could see. And I don't know if you can see it underneath, but there's some bluish color. And those are some of the connective tissue fibers being stained. So I would call it the second layer. There's like a blue line kind of. And then you see the hyaline cartilage, you can definitely see, and that's the third layer. And then the fourth layer is called serosa, or actually in this case, we're going to call it adventitia because it's, we call it adventitia when it's like a tissue because it's connected to another tissue. So for the most part, the esophagus is kind of connected to the trachea. Like if you were to do an autopsy and you were to pull the trachea out, the esophagus would be behind it and it would come with it. You'd have to kind of tear it off. So anyway, that's more anatomy. And this is kind of how the air moves through to get to the lungs. Right? So it starts up in the mouth or your nose, right? You're breathing it in through your nostrils, your nares, Nares. That's your nostrils. You're breathing it in, goes into your mouth, nose, whatever, ends up in your pharynx. It starts to go down your trachea. So moves past your larynx, moves down your trachea. At the bottom of the trachea, you have I remember now, we were looking at this in lab, some of us. At the bottom of the trachea, you have what's called the carina. That's like a triangular piece here, and that's where it bifurcates into the right and left. So you see here trachea, and then you see primary bronchi. Primary bronchi is right and left. They're rather small sections. Let's look at this right side because it's looking a little bit easier to figure it out. All right, you see how it's like from the trachea, it goes to the right, and then it's going to split again. So it branches again right about here. And that would be the secondary. That would be the secondary bronchi. So the secondary bronchi goes to each lobe, and that's not really clear in this photo. Like you can't tell that a secondary is going to the superior, middle, inferior, but it does, right? So secondary goes to each lobe. And then once it's in the lobe, it branches into tertiary bronchi, and that's like these little ones that you see here. So you're going from primary bronchi, primary goes to each side, secondary goes to each lobe. Once it's in the lobe, it goes into tertiary bronchi. And you can kind of see the tertiary up here. And maybe like at the end here, these little tiny things, you're looking at bronchioles, little bronchi. That's small enough at that point that you're going to get some blockage. So somebody with asthma or something, likely that, or bronchitis, it's likely that the problem is that the bronchioles, because these tubes are a little bit bigger, right? And the bronchioles do have some muscle associated with them. There is some ability to constrict and dilate. And then it goes to terminal bronchioles, and there's even something called respiratory bronchioles, but let's just stay with terminal bronchioles here. So even smaller than the bronchioles are the terminal bronchioles. And then after that, I was telling you in lab, it turns into something that looks like a thing of grapes. So you got like the stem that you would pick up the bunch of grapes with. You pick it up by like the stem. That stem that you'd be holding on to would be like a bronchiole or a terminal bronchiole. Say a bronchiole, right? And then you've got like these little tiny stems that you pick the grapes off of. That would be like a terminal bronchiole. And then the grapes would be something called an alveolus, which we're not even seeing yet. I'm going to go back, but here we go. So there's like a grape. Here's a grape. Here's a grape. There's just a bunch of those. All right. So that's the alveolus or alveoli. Like it's written right here, alveoli, meaning like plural, alveolus, meaning singular. That's where you have exchange between the lungs and the blood. This is where oxygen is going to enter the blood and this is where carbon dioxide is going to enter the lungs at this point. We call it the respiratory membrane. So the membrane in between the blood capillaries and the lungs, right? So there is an end to it, right? You go from a trachea, and then it gets smaller. Primary bronchi, secondary, tertiary bronchioles is getting smaller and smaller, more numerous, more numerous. There is an end, like a cul-de-sac, when you get to the alveolus. So maybe this thing up here would be better if they put one more arrow down and then they put alveoli below that. Notice the diaphragm underneath it. And that's relaxed. Notice how the diaphragm is like curved up. It's concave or convex, something. It's not flat. When it contracts, it becomes flat. When it's relaxed, it's like curved up. I don't know what this. Well, oh yeah. So let me just mention this. I'm not gonna, again, not testing you on this, but let me just mention it. Just like the heart has the pericardium, the lungs have something around it as well, and there is fluid in between. So there's like kind of a sac, not really a sac, but there's something around the lungs, and there's fluid in between the lungs and then the membrane. So we call that the pleura. Pleura. And you see here, they're calling this in this photo, they're calling this the parietal pleura. And here we go, there's a visceral pleura. So you've got these two words here, visceral and parietal. Visceral means the closest to the organ. It's usually surrounding the organ. Parietal means further away. Same thing with the pericardium. You have what's called the visceral layer of the pericardium and the parietal layer of the pericardium. The visceral layer is like right on the heart, touching the heart. It's closest to the organ. The parietal layer is like the sac around the heart. Same thing here. I guess that's just an FYI thing. And you have fluid in between the visceral and pleural layer. And sometimes that becomes all inflamed. And so they call that pleuritis. Just like you can have pericarditis, you can have pleuritis. So when you see the word pleural, Pleur, it has to do with the lungs. If you see it in another word. More anatomy here. This is called a hilum. So the hilum is, and maybe if you could picture a kidney, like a kidney bean shaped thing, right? You know where it kind of like dents in and you got all the blood vessels that go into that? That's called the hilum. Same thing on a kidney or even on a lymph node, or here it's the same thing. It's where the bronchioles, or where the bronchi go in, where the blood vessels go in. It's on the medial aspect of the lung. Call these fissures. We're going to deal with that in lab. So let's go back to this. So yeah, you see the alveolus here, and then you see it's covered with pulmonary capillaries. So this is where blood vessels are. This is where the blood meets the lungs. So, you've got deoxygenated blood coming through here, and then right here, where it's kind of not blue, not red, it's kind of in between or both. Carbon dioxide's moving into the alveolus. The oxygen's moving into the blood. So you have deoxygenated blood coming through the blue part, and then you have oxygenated blood going back into the red part. Right? So it's looking here, it's saying pulmonary venule. That's going to become a pulmonary vein, and that's going to go back to your heart. And then pulmonary arteries, they become pulmonary arterioles. they become pulmonary capillaries. So it's the same words, artery, arterial, capillary, venial, vein. It's just that we're using the word pulmonary with it, but same idea. So inside the alveolus, we have different types of cells. We have type 1 cells and type 2 cells. I know I'm moving around a lot. I hope you're looking at the words and not the picture of me moving around. So we have cells in the alveolus, type 1 and type 2. Type 1 just are cells that, I'll go back to that one, are cells that line the wall, right? This cell, that cell, that cell, that cell. These are all alveolar cells. It's simple squamous, meaning it's one, like a single layer of flat cells. As it should be, because oxygen's going to move across those cells. So oxygen has to come in here, and it's got to squeeze between the cells and go into, and it's got to squeeze through the wall, the capillary wall, right? So you actually have two layers of epithelial cells here. You've got the layer of epithelial cells that's lining the alveolus, because the lining of everything is epithelial tissue, right? So the lining of the alveolus, epithelial. The lining of your capillary, also epithelial tissue. So you got two layers of epithelial tissue, and the oxygen's got to get past both of those layers. And of course, the carbon dioxide also has to get past both of those layers. So as it's labeled here, we call it the respiratory membrane. Here's a larger or more detailed photo of it, right? So you move through the epithelial layer of the alveolus. So it's a single layer of squamous cells. Then usually epithelial tissue is attached to a basement membrane. So you got to move through that epithelial tissue, and then there's a basement membrane right underneath it. And then you have the same thing for the blood vessel. So you have a layer of basement membrane and a layer of epithelial tissue. So it's like a sandwich with, I guess, two slices of meat, and the two slices of meat represent the basement membrane, and the two slices of bread represent the epithelial tissue. You've got one slice of bread with a slice of meat. You got the other slice of meat and another slice of bread. I don't know. But that's all it is, right? But here's the thing. You got to keep the lungs moist. This can't be dried out. You can't have your lungs dried out. And so that presents a problem. You got to, it's moist, and there's like a thin layer of water. But water has a high surface tension. Like, it's hard for things to get past that water layer, right? And that's the problem oxygen has. It can't get through the layer, like the wetness of it. It can't get through the water to even start going through the respiratory membrane. So you have type 2 cells, which are called septal cells, and they produce surfactant. Surfactant lowers the surface tension. Water has too high of a surface tension for some things. And you can feel it if you've ever belly flopped into a swimming pool. It acts like a hard surface for a brief moment, right? Water's not like falling into a foam pit or something, right? It's not necessarily soft. It'll break bones. It'll kill you. I mean, if you fall into it the right way, right? But anyway, so you have to lower the surface tension of this fluid that's here, and that's what surfactant does. So these type 2 alveolar cells, they lower the surface tension. That is primarily the reason why. Preemies are still in the hospital. So, yeah, they don't make surfactant. They've got the lungs. Premature babies, they'll keep them in there for a little bit of time, and it's all about the lungs, right? Because the lungs are one of the last things to fully develop during embryology. But more specifically, it's the type 2 alveolar cells that aren't developing. So they're not making surfactant. So these babies can breathe, like air, like oxygen goes into their lungs, but it never crosses over into the blood. So they're breathing in oxygen, they're breathing out oxygen, right? So you've got to put them on supplemental oxygen. You got to kind of put some pressure on that because they haven't been able to make enough surfactant yet. And as soon as you let them, give them a couple weeks or a few weeks or whatever, and they'll make it, and then hopefully let them out and everything's fine. But that's two types of alveolar cells. Anyone have any questions so far?
No, sir.
We're moving into physiology now. So if you haven't been taking notes and you are someone that takes notes, this would be a good time to start taking notes. There's going to be 3 laws that we're going to deal with when we talk about this chapter. One of them is called Boyle's Law. And I think I have them summarized. Yes, right on the next slide. Right. So Boyle's Law is just what I put here. Inverse relationship between volume and pressure. When the volume becomes less, the pressure goes up. So think about a bottle of water. You squeeze it, the pressure inside goes up. You're squeezing it, you're making the volume less. Same idea with our blood vessels, right? When you constrict your blood vessels, the blood pressure goes up. When you dilate your blood vessels, pressure goes down. Same thing with your lungs. If you make the lungs bigger, the pressure drops. If you make the lungs smaller, the pressure goes up. So that's essentially Boyle's Law. And I want you to know these 3 laws and how they apply to this chapter. We actually just talked about Boyle's Law. Lungs get smaller, pressure goes up. Lungs get larger, pressure goes down. Then we have Dalton's Law. Each gas exerts.
So for Boyle's law, if the pressure goes up, the lungs get larger?
No. The lungs get larger, and therefore the pressure goes down.
Okay, and if
the
pressure...
the opposite, inverse. When one gets bigger, the other gets... One goes up, the other goes down. So lungs go bigger, pressure goes lower.
Okay.
Just like your blood vessels. They get bigger, your blood pressure goes down. If you constrict them and make them smaller, blood pressure goes up. If you look at the air around us, most of this air is actually not oxygen. Only about 20% of this air is oxygen. 19.8 something. About 20%. Right. About 75% of the air around us is nitrogen. So this is all nitrogen. It's just that we don't really break it down. We breathe it in, we breathe it back out. It's very tightly bonded together. We have a difficult time. We don't want to deal with it anyway. So that's good. Right. But most of it's nitrogen, about 20% of it's oxygen, about 0.3. So let me give you some better numbers. 78% is nitrogen, about 20% is oxygen, right? That brings us up to about 98% of the air. Then the rest of it, there's some carbon dioxide in there. there's some water vapor. Um, but there's different gases, right? So you have carbon dioxide, you have nitrogen, you have oxygen. It doesn't, one gas pressure does not influence the pressure of the other gases. So if the pressure of nitrogen goes up, it doesn't affect the pressure of oxygen. The pressure of oxygen in this atmosphere, it's got its own pressure, and it doesn't depend on anything else. It's independent. So we measure pressure in millimeters of mercury. So mmHg. That's how we measure pressure. Like in blood, your blood pressure is 120/80. That's millimeters of mercury, mmHg. Same thing with air. This air has pressure. It's all together, taken all together. The air pressure outside is about 760 millimeters of mercury. Not that number is like super important, but it's about that at sea level. And the pressure of oxygen in this air is about 160. You got to take about, so if you take about 20%, let me see, 760 times 0.198, 150, somewhere between 150 and 160 millimeters of mercury. Right? Just like the pressure of oxygen in my lungs is somewhere around 100. And the pressure of oxygen in the arteries in my arm is somewhere around 100. But the pressure of oxygen in my veins coming back up is a lot lower. It's like 15. Right? So it's just how much pressure is in that oxygen. So Dalton's law is saying that each gas has its own pressure, and it doesn't matter what the other gases are doing. So you'll see it written sometimes, instead of saying like CO2 or O2, it's going to be a big P, PO2. And what that means is it's the partial pressure of oxygen. So I could say the pressure of the air around us is 760, but the partial pressure of oxygen, PO2, is 160. What I'm saying is, what's the pressure of oxygen just by itself? Forget everything else. Third law is Henry's law. How much gas will dissolve in a liquid? So what we mean here, what's the gas we're talking about here? We're talking about oxygen and carbon dioxide. So let's just talk about oxygen. The amount of oxygen which will dissolve in a liquid depends on, the liquid here is blood. So let's redo it. The amount of oxygen which dissolves in blood depends on two factors. So the amount of gas which will dissolve in a liquid is proportionate to the pressure of the gas and the solubility of the liquid. So how much oxygen will dissolve in blood? Because just because there's oxygen in the air and you're breathing it in, that doesn't mean everything's done. You might breathe it in and breathe it back out. The partial pressure of oxygen here at sea level is like 160, around, right? I don't know if you remember that I told you what it was in your lungs, a nice even number. Like, what is it inside your lungs, the pressure of oxygen? It's about 100. So the pressure of oxygen outside in this air is like around 160. In our lungs, it's around 100. Higher pressure always goes to lower pressure. So we've got a difference here between 160 and 100. So the higher will always go to the lower. But what if we're at 10,000 feet in a mountain? The partial pressure of oxygen is no longer 160. It goes down. As you go up in elevation, the pressure goes down. So at 10,000 feet, the pressure is like 110. right? So now you're going between 110 and 100. It's not as big of a difference, right? So you don't have as much diffusion. And then once you go up to 14, 15,000 feet, it starts to approach zero. You get to, I don't know where that point is, but if you go high enough in the mountains, at some point, the oxygen is not going to cross over because the pressure is the same. The pressure in your lungs, the pressure in your blood, it's equalized. So the oxygen is not going to go over. You got to have higher pressure in your lungs than your blood. So that's what Henry's law is saying, that when you have a higher pressure of gas, more of it is going to go into your blood. So the amount of oxygen that will dissolve in blood is proportionate to the pressure of the oxygen. That's why for some people with COPD and stuff, they put them on like a nasal cannula, like they're breathing it through their nose, or they'll put a rebreather on them. They'll give them 15 liters of oxygen. You just give them more oxygen, and the pressure is higher. The other thing is the solubility of the liquid, meaning that how accepting of is blood. How much does blood accept the oxygen? There's different factors that cause the oxygen to stick to the blood or not stick to the blood. Because if the oxygen just comes to the blood and bounces off, then how are you going to get that oxygen down to your feet or wherever you have to get it, right? You want the oxygen to come in and not bounce off. You want it to stick, and then we take it to where it needs to go, right? So one thing is that you got to get the oxygen through the blood vessel and to get into the blood, but then once it's in the blood, it's got to like stick to all the red blood cells. You can't just bounce off. So we'll talk about that in a few slides, but these are the 3 laws that I want you to know, that I'm going to ask you about. I'm going to ask you about these. Questions on these laws? The examples that I just talked about, if you didn't get it, don't worry. I'm going to go into them. I'm going to take each one. Okay, so let's take the first one, Boyle's Law. We're talking now about factors in inhalation, breathing in. What makes you breathe in? Well, it's an active process. Active means we need energy for it. Passive means it just happens automatically. You don't need energy. So active versus passive, do you need energy or not? Right? Breathing out is passive. Exhalation is passive. That's what I wrote up here. Because your lungs are like elastic, right? So when they get bigger, it's like an elastic band, right? You're making it bigger and it just wants to snap back. So that doesn't take any energy, right? You use the energy to make it bigger, right? When you take an elastic and a rubber band and stretch it out, you're using energy to make that happen, right? But to make it snap back, you don't have to do anything, right? So breathing out should require no energy, no effort. In fact, if it does, that's a sign that something's wrong. So you can look at a person, if they're breathing out, they're like something's wrong. So what is the energy being used? Well, right here, the diaphragm is getting contracted. And you have, less importantly, some muscles in between your ribs, the external intercostal, right? Costal means ribs, inter in between. So you've got like different layers of like muscle in between your ribs. Ribs. When you eat ribs, you're eating different layers of muscle. You just can't see it. But if you were to try to, before you cook the ribs, you could tease out 3 layers, right? So internal, external, and something else, another external layer. I think it's called whatever. Who cares, right? So the external layer of intercostals lift the rib cage. When you lift the rib cage, that gives more space for the lungs to get bigger. All right, so you're taking your rib cage here and you're lifting it. It's like lifting I think of like a bucket handle right here. So you see how like when the bucket handle's against the bucket, there's not as much room. When you lift the bucket handle, you've made more room. That's what's happening with your ribs. When you lift the rib cage, it makes more room for the lungs to get bigger. But more importantly than that, when you flatten the diaphragm, see here it's not contracted, here it is contracted. So you've made space. When you flatten that down, you made space for the lungs to get larger. So both of these things, diaphragmic breathing, or the diaphragm and the external intercostals, both act to make the lungs bigger. And I'm saying it here, contracted diaphragm increases pulmonary volume. It makes the lungs bigger. Boyle's law says that when you make the lungs bigger, the pressure goes down. So the diaphragm makes the lungs bigger. Contracting the muscles between your ribs and lifting your rib cage, that makes the lungs bigger. Both of those things are going to lower the air pressure in your lungs. And yeah, we call it diaphragmic breathing. Eupnea, the PNEA just means normal, like PNEA has something to do with breathing, like the word pneumonia. Pneumonia has that PNE in it, right? So when you see that in a word, it means like breathing. EU means like normal. So eupnea is just normal breathing. So your diaphragm is responsible for about 75% of your breathing. And your intercostals are about the other 25%. When people are breathing really shallow, we can refer to that as costal breathing because they're relying more on their intercostals than their diaphragm. But anyway, they both work together normally. Under normal circumstances, they both work together to let you breathe, to make the volume of the lungs larger. When the volume of the lungs is larger, the pressure drops down. So I'm not concerned with the actual numbers here, but what I want you to see is that one's higher and one's lower, right? So this is when your diaphragm's relaxed, your lungs are smaller, and the pressure inside of your lungs is about 760. The pressure outside is about 760. So in this case, the pressure is 760, the atmospheric pressure, the pressure outside is 760. They're both 760. That means there's no movement. You're not going to have air going from one place to another because air only moves from higher to lower. Watch Margaret Orr. She's always going like the H's and the L's, and she's going like this and stuff. And I just want to know, is it going to rain this weekend or not? I don't want to wait 15 more minutes. But whatever, that's what it's all about. Whatever's happening where the H's are and you're in the L, that's all coming to you. Because higher pressure goes to lower pressure. Same thing in your lungs. So if you look on this side, the diaphragm contracted, the lungs got bigger, the pressure inside the lungs is 758, and the pressure outside is 760. So now you're going from higher pressure outside to lower pressure in your lungs. So the air wants to go in your mouth, down your trachea, into your lungs. It wants to go where the pressure is lower. So that's what's making you breathe in. You are not sucking air in unless you're thinking about it. Hey, I'm going to suck some air in. You force yourself to breathe in. That's different. But normally, the lungs are getting bigger, the pressure's dropping, and the air from the outside goes into your lungs. You're not drawing it in, it's going into you.
So far, you're just pretty much saying that when your lungs are at rest, you have more pressure in the inside than outside, and then when you inhale, the pressure is more on the outside than inside, and then you go back to relaxation, or
But you're inhaling because the pressure is lower on the inside than the outside.
okay.
That's what's causing you to breathe in.
So it's kind of like a forcement.
Yeah, it's not a result of breathing in. It's like because that happens, air goes into your mouth and into your lungs. That's what's making you breathe in because the pressure's lower in your lungs.
Okay. Okay.
That's all Boyle's law. You know, lower volume, higher pressure, higher volume, lower pressure. That's all Boyle's law. What makes you breathe in?
So the factors of this slide right here is just pretty much based off of Boyle's law.
Yes.
Does it base off of the other two?
No.
No?
So this is just saying, you know, what makes you breathe in. What makes you breathe out is very easy. I actually put it in here. I just said, well, no, I didn't. Breathing out is mostly what we call elastic recoil. Like recoil, like the elastic snapping back. Because your lungs have some elastic fibers in them, a lot. So they're like rubber bands, kind of. People with COPD, sometimes, some people, you imagine like the elastic in like your underwear or something when it just starts going out, you know, then it doesn't stay on you anymore. It just stretches out. That happens with some people with COPD. So what you'll see is that it's easy to breathe in because they're not trying to stretch the rubber band that's their lungs. So they can breathe in quick. But when it comes time to breathe out, the elastic's not snapping back because the elastic fibers are getting destroyed in their lungs by like emphysema or something. So they have to help push it out because the elastic's not just snapping back like it should. You can find the opposite problem too when the elastic starts to become too strong. Like when the oxygen can't move through the lungs good enough because it's all like there's fiber on the wall of the lungs and the oxygen can't bust through. So it's like pushing it. And the elastic is like really hard. It's really hard for them to breathe in. But when they breathe out, it's like, because it's like, I don't know, that probably doesn't, I'll show it to you in another slide. Anyway, that's what helps you breathe in. That's what makes you breathe in. Breathing out is elastic recoil. I don't know what that slide is. Yeah. Breathing out is elastic recoil. There are muscles that can help you breathe out. If you're like working out or something, you know, you're also breathing out, right? Because you're winded, you're out of breath. So there's the internal intercostals, help you exhale, right? Internal intercostals to exhale, external intercostals to inhale. Let's look at this. So here we have some like lung volumes and lung capacities, and I want you to have a good I might have written it. I did. So let's look at this. So let's look at this first one. This is a lung capacity. This is tidal volume. So tidal volume, just think of the tide, right? The tide comes in and out, a normal tide, just in and out all day. That's tidal volume. So how much oxygen is going in and out with every breath? On average, about 500 milliliters. So 500 milliliters is about a bottle of water, right? It's half a liter. Here we're not measuring liquid, we're measuring air, but that's about how much goes in and out of your lungs. So that's what tidal volume is. But your normal breath, that's not what you're capable of. You can get a lot more air in your lungs than just what your normal breath is. When someone says take a deep breath, now you're tapping into your reserves. You're taking your normal breath, but you're even going more. That is inspiratory reserve volume. How much can you breathe in, like maximum? So you breathe your normal breath, but how much more can I get in there? And look, you can get in another 3 liters or 3,100 mils. So we call that inspiratory reserve volume. And then you can say the same, like whenever you breathe out, like a normal breath, you're not breathing everything out. You're not going maximum, right? You're just breathing out. But what if someone said, breathe out everything you possibly can that you're capable of doing? You're not going to breathe everything out of your lungs because your lungs would collapse. Your body won't let you breathe in, breathe out everything. It's so, what's left over is like 1.2 liters or 1,200 milliliters, right? Residual volume. That means that your body's not going to let you breathe all your air out. But you can breathe a lot more out than normal, right? If you just keep breathing out, you can breathe out like expiratory, you can expire. How much reserve do you have in there? How much could you really breathe out? Another 1,200 milliliters. That's not all of it. But let's say after a normal breath, you could breathe out like half of what's left, right? You breathe out normal and then stop, normal breath out. You've got about 2.4 liters left in your lungs. You could breathe about half of that out. It all means something. Like you look at these things to measure respiratory function. How is your lungs working? Different diseases produce different different numbers here. But how much can your lung, like what's the capacity? What's the total capacity? Well, you just add these two together. Like what's your normal breath in plus what can you hold in maximum? But I mean, from this, I think I wrote it down here. So tidal volume, they kind of write it as that sometimes, 500 milliliters. Of course, that's one breath, right? You don't want to take just one breath. So you have to count, you have to do it by the number of minutes. So a minute ventilation will be your tidal volume times a minute. And you breathe in about 14 to 20 times a minute is about 12 to 20 times a minute is about your, how many times you breathe in. So if you were to come up with like a number, say you breathe 16 times a minute, right? So you just take your tidal volume, which is 500 times 16, and that would give you a minute ventilation. Some people that are, so respiratory rate, a normal respiratory rate is like 12, 14, 18, 16. I think we were talking about this, like nobody really counts them. They just have a number in their head and they just put that. But someone panicking, they'll be at 30. Someone totally freaking out, they could even be higher than that. Somebody OD'd on heroin, they might be 8 or 4. I've seen 4. You're breathing 4 times a minute. And you know, when someone's not breathing, 15 seconds or 10 seconds is a hell of a long time. By the end of that 10 seconds before their next breath, you're like, oh, they're dead. Right? It's just time is a lot different. Just like when kids when they choke and not breathe, it feels like a half hour. Like they're dead. They're dead. It's only been a couple minutes. Right? But when you're freaking out, time is just completely different. Which is interesting, huh? Because time's not really fixed. We try to fix time, and time is relative. It's not at all fixed. You know, if you're 25, you know, 1 month or 1 year for you is way different than my notion of a year. A year for me, just right. I'm dying. I'm 51. I'm on my way out. It goes quick. I can see next year like it's next month for you, right? So it's like time's really all right. Anyway, I know nothing to do with this. Let's look at alveolar ventilation rate. All I'm saying here is that when you take a breath in, it's not all reaching your blood, right? Like I take a breath in, and now I'm going to breathe out, but some of that air, that last bit of air, is trapped in my trachea, or it got into my lungs, but it didn't get all the way to the end. So I just breathed it back out. So only about 70% of your oxygen of the air actually reaches your alveoli. So the other 30%, you know, like let's say the stuff that was stuck in my trachea and it never made it. It was last in line to get into my mouth. It never made it. That's anatomic dead space, right? I breathed it back out. So if you wanted to really look at like an alveolar ventilation rate, then the question is how much of a normal breath actually reaches your bloodstream? That's about 70%. So this is kind of going on to Dalton's law. Let me see what time it is.
So the lungs volume also goes with Boyle's law. Or can that apply? Does that apply to all of them?
Yeah, all and none. These are just more like capacities that you might take in a hospital. Yeah, because we're not really messing with pressure here. So this wouldn't really apply to Boyle's law so much. But the next one's going to apply to Dalton's law.
Okay.
Because you're seeing it's kind of small. I can't make it larger, but you see it says like PCO2, PO2. All these have P's in front of them. They're meaning partial pressure. So the atmospheric air is 760, but the partial pressure of oxygen in the air around us is only 159. And the partial pressure of carbon dioxide in the air around us is not even 1, 0.3. So what the point is on all this when I start going over it is that pressure goes from higher to lower. So let's follow oxygen. Let's go the other way. Let's follow carbon dioxide. Carbon dioxide is made by all of our cells, right? All of our cells make it. It's a waste product. So carbon dioxide is made by the cells in our hands, for example. All right, the oxygen comes in to the hand, feeds all the cells, and then carbon dioxide is made, and now it's got to go back into that blood, and I got to get the carbon dioxide out of my body. It's all on pressure differential. The oxygenated blood in my hand has a low pressure of carbon dioxide in it. It's only about 40. But the pressure of carbon dioxide in my cell is 45. So it's 45 in my cells in my hand, but it's only 40 in the blood. So the 45 is going to go to the 40. Higher pressure to lower pressure. So if you look at the deoxygenated blood, and we're looking just at carbon dioxide here, what's the pressure of the blood going through my artery in my hand? It's going to be 45. What's the pressure going through my veins back to my heart? It's 40. I reversed that though, so that probably made no sense. The pressure of carbon dioxide going this way to my hand is 40, going back 45. Right? So the 40 came in, picked up all the 45 from my cells, it became 45, and then it turned around. Right? So it was 40 coming in, but all the pressure of carbon dioxide in my hand's 45. So the 45 went to the 40 until that blood became 45. So it's like down here. Here's the oxygenated blood, the pressure's 40. As it's going by my cells, all that carbon dioxide's moving into the blood until it becomes 45. So it's like 40, 41, 42, 43, 44, 45. Right now it's deoxygenated blood going up my veins. It's 45 now. Then that 45 gets to my lungs. And look at the pressure of carbon dioxide in my lungs. It's only 40. But the blood next to my lungs is 45. So the 45 is going to go to the 40, higher to lower. So that's what makes the carbon dioxide move from my blood into my lungs. And then in my lungs, it's 40. But what about the air around me? 0.3. So it's like a big difference. So for my lungs, it just wants to go out. It doesn't matter what the pressure of oxygen is. We're just talking about carbon dioxide. It's got its own deal. It does it. It's not concerned with any other gas. And then oxygen is going the other way, right? Oxygen comes from this air around us. It goes into our body. Ultimately, we want to get it to all of our cells. Well, how do I move oxygen from the air around me to my feet? Well, you breathe it in. Okay, fine, I breathe it in. Then what? I got to get it into my blood. I got to get my blood all the way down to my feet. And then I got to get that oxygen out of my blood and over to my cells. Like just because I breathe it in, that's not the end of the trip. I got to keep moving it. It's all pressure, pressure, pressure. Pressure of oxygen outside in the air, 159. What is it in your lungs? 105. So the 159 is going to move to the 105. Okay, that's not it. I got to get it into the blood. So what is it in the blood? It's about 40. So you're going from 100 to 40. So the oxygen just moves into the blood because the partial pressure of oxygen here is like 40. So as the blood's coming by the lungs, oxygen starts filling the blood until that pressure gets up to like 100. So in your deoxygenated blood, the pressure of oxygen is like 40. Once it becomes oxygenated, it's up to 100. And then now that blood's on its way to the cells. When it passes the cells, all the oxygen leaves the blood and goes into the cells. Because you see the pressure difference. The pressure of oxygen in your blood is 100. The pressure of oxygen in your cells, 40. So yeah, it's going to move across. It's going to keep moving until the pressure drops down to 40. See how it says like oxygenated blood, it's 100 here. And then you look at deoxygenated blood here, it's 40. It just keeps, as it's going by your cells, it just keeps going lower, 100, 90, 80, 70, 60, 50, 40, because you keep losing oxygen out of that blood. It keeps going into the cells. So the pressure's dropping. If I went too fast or if that didn't make any sense, if you kind of stare at this photo for a while and just remember, oxygen moves from a higher pressure to a lower pressure. As long as you remember that, it'll make sense. And carbon dioxide moves from a higher pressure to a lower pressure. And just think about where it's going. Oxygen's always moving in one direction, from the air around us into our cells. Carbon dioxide is always moving in the opposite direction, from our cells to the air around us. And then just think about it and follow it through, and you'll see it's just going from higher to lower pressure. And all the P's mean partial pressure. Oxygen does oxygen. Doesn't care about what carbon dioxide is doing. So they're saying, what's the...
So oxygen moves from higher pressure to lower pressure.
Always.
Always.
And the only reason you're breathing in is because the pressure of oxygen is higher in the air in that room you're in than it is inside of your lungs. So it wants to be in your lungs. Once it's in your lungs, it finds a place where the pressure is even lower. It's like, oh, look at that blood. That's even lower. I want to be there. Or picture it as like being less crowded. Right? Oxygen wants to go where it's less crowded. There's not all these people around. So it just keeps moving and moving to a place that it finds less crowded. Once it gets in your blood, it starts traveling around your body. It sees some cells and it's like, oh, that's even less crowded. I'm going to leave the blood. I'm going into the cell. That looks even better. Less pressure in there. Nobody wants to be under all that pressure.
So oxygen. So if the oxygen moves from higher pressure to lower pressure, and carbon dioxide, it doesn't. It
does the same. It wants the same thing that oxygen has. It wants from higher pressure to lower pressure.
Okay.
If you take like perfume and you spray a little bit of it like in the corner of your room, it's not going to stay there. It's not going to be like someone's going to walk in and never smell it until they walk up on you. That perfume's going to like diffuse and like spread across the room. That perfume doesn't want to stay in a cloud right where you sprayed it. Because that's just, these things want to spread out and go from higher to lower. It's all diffusion. Gases diffuse. That's the point. Like water diffuses, gases diffuse. Everything diffuses in our body. It goes from higher to lower. It's that idea of diffusion. And diffusion's a passive process, actually. You don't need to force oxygen to go into your lungs. As long as the pressure is lower in your lungs, it wants to go into your lungs. This is the third one. This is Henry's law. So how? Well, actually, this is kind of pre-Henry's law. This is talking about like how fast this thing will happen, how much, like the rate of gas exchange, like how the extent to which it will happen. Depends on how much pressure is in the gas. So if you're giving pure oxygen to somebody, the pressure is a lot higher than 159. So it's going to go into your blood more. But like I was saying, when you get up above sea level, when you get up like at 10,000 feet, the pressure of oxygen is lower. It doesn't mean there's less oxygen.
this air at sea level in New Orleans, oxygen's about 19.8 or 20%, something like that, right? At the top of Mount Everest, oxygen's also 20% of the air. Same amount of oxygen, it's just not pressurized on the top of Mount Everest. You could breathe it in, it's not going anywhere. There's no higher to lower. It's not going to move into your, well, it's not even going to move into your lungs. You would have to like force it in. And even then, it's not going to move to your blood. It's not going to go anywhere. It's not like, oh, hey, look, it's less crowded inside the, no, not at Mount Everest. Or like an airplane, they pressurize the cabin at 10,000 feet because as you start getting above that, the oxygen's not going to go anywhere. They're not increasing the oxygen on the airplane. They're increasing the pressure, really. What are they doing? They're pressurizing the cabin. And then the surface area, right? If you've got something like pulmonary fibrosis, it sclerotizes your lungs. It takes the alveoli, like your body will attack the alveolus, and it'll like your like pulmonary fibrosis is like an autoimmune disease, and it makes your immune system starts attacking these epithelial cells. And these your body's going to react to that. Your body's attacking itself, but it also reacts to being attacked. And your lungs react by becoming harder. It makes like scar tissue here, and it becomes harder. It's like a defense mechanism. And then we can't get the oxygen.
Was that two different slides, or was that one slide?
Moved around a lot. One slide.
Okay.
So like when you make when you sclerotize or when you harden the alveoli, then the oxygen can't cross over into the blood. So that's going to affect the gas exchange. Because gas exchange, what we really mean is oxygen going into the blood, carbon dioxide leaving the blood at the lungs. We're not talking about just breathing in and breathing out. That's not enough. We got to get that oxygen into the blood. If the wall's thicker, you're not going to be able to get that oxygen past. So then what we could do in that case, somebody that has like sclerotized lungs or something, you got to give them oxygen, right? You got to make the pressure higher. So, when they've got those cans of oxygen, that's like, pure oxygen, or you're increasing the amount of oxygen, which makes the pressure go up. So the pressure on their lungs is higher than us. So that's making it cross through. You're buying some time. But eventually, all those alveoli are going to harden up, and the oxygen, even if you give it in as a gas, like as a tank of oxygen, it's not going to cross over. Of course, when that's happening and oxygen's not getting into the blood like it should, then that's kind of a type of shock, really. And so your body's going to respond to that. Your heart is going to like beat harder and harder because it's trying to pump blood around more to compensate for the fact that there's not a lot of oxygen in there, right? It's trying to beat more and harder. And eventually you're going to overwork the heart. It's going to stop. So a lot of people that have like certain types of COPD, like chronically a long time, they'll have heart problems. Like the heart's going to stop hopefully before the lungs stop working completely. Um, I don't know why this is. I know why it's on there. I just didn't want to talk about it. All right, let's look. This is the third. This is Henry's. This is sort of Henry's because we're talking about the partial pressure of the gas. But this is really Henry's law. Well, Henry's law is two parts. The solubility of the gas, the solubility of the liquid and the pressure of the gas. Right? So as the pressure goes up, more of it goes into the blood. But that's not the whole story. We want it to stick to the red blood cells. The red blood cells are the ones that carry the oxygen through your blood. But if you remember, red blood cells are essentially just hemoglobin, just masses of hemoglobin. So what we're really saying is, how do we get the oxygen to stick to the hemoglobin in your blood? And that's what affinity means. Affinity means like to like something. How do we make the oxygen like the hemoglobin in the blood? I don't know why I go like this, like that's not helping you. Oh, you get it now? I went like this. So how does the oxygen stick to the hemoglobin? Like what makes it want to stick to the hemoglobin? These four factors that you see in front of you. Some of them are planned, things that we want to happen, and some of them are unplanned. The first two are unplanned. Things we don't want happening. Lower pH. When your blood becomes acidic, it decreases the affinity, meaning that oxygen doesn't stick to blood as well, to hemoglobin. So acid ketosis, one of the signs is like elevated respirations. It's really not, this is like an aside, but what's making, we always think what makes us breathe is that we want oxygen. Oh, that body's not getting oxygenated. They're not getting enough oxygen. It's really the other way. We're not able to get rid of carbon dioxide. That's what does us in. Yes, it's important. We need to get the oxygen. But why do we need the oxygen? Because we use the oxygen to get rid of carbon dioxide. The oxygen comes in, grabs the carbon, and takes it out of the body. So really what's happening, like when you hold your breath and you're like panicking, the carbon dioxide is building up in your body. That's what you're feeling. So it's really what it is. You're trying to get rid of carbon dioxide. Carbon dioxide makes things acidic. When you're holding carbon dioxide in your body, your cells you're making an acidic environment. That's what's going to break open your cells. That's what damages your cells. The buildup of carbon dioxide, not the lack of oxygen. I know it means the same thing, right? So if you're not getting oxygen, it's the same thing as saying you're building up carbon dioxide. But I was thinking of the person in like ketosis. They're breathing a lot, right? But their body's doing it not because it wants to get oxygen as much as it wants to get rid of carbon dioxide. That's what's making them breathe faster. But anyway, back to these four factors. pH. Lower pH. Lower pH means more acidic. Higher pH means less acidic. Don't forget that. Even me, I confuse it. Lower pH is more acidic. Increased carbon dioxide. So when you have more carbon dioxide in your blood than you should have, some of that carbon dioxide is going to jump on the hemoglobin and take some of those seats away from oxygen. Which means when oxygen tries to jump onto hemoglobin, there's no space. The next two are planned. Heat. Oh, look, I spelled it right. Heat decreases affinity, meaning that when your body's hotter, the oxygen doesn't stick to hemoglobin as well. In this case, you want that because we're talking about when the blood gets to your cells, right? So here's the thing, you want the oxygen to like stick to your red blood cells, but you also want it to break off. when it's time to get off and go to your cells, you need to get off. You don't want to like attach to the cell, make it down to your kidney, and then not get off and stay on, right? Especially if you're sick or something, you need that oxygen off of the blood, and you need it to get to the cell because you have a whole immune response to activate, right? You need energy. You don't want that oxygen just staying around on the blood. So you need to get it off at certain times. That's what like a fever helps to do. So sometimes heat, up to a point, right? If your fever is way too high, then that's what you don't want. But heat is kind of like a good thing. You want oxygen to attach, but you also want it to break off so it can go do what it's supposed to do. And BPG, same idea. BPG stands for biphosphoglycerate, but you can call it BPG. Oh, there it is. Yeah. So certain hormones increase this chemical called BPG, and that will decrease how much oxygen sticks to blood. So in the case of like human growth hormone, yeah, we don't want oxygen to stay on your red blood cells. It needs to jump off and go grow your bone or your skin or whatever, because you're trying to grow. So these are your 4 factors. These all tie into, I'm going to go back for a second. These all tie into Henry's law. The amount of gas that dissolves in a liquid is proportionate to the solubility of the liquid. That's what we were just doing. We were just talking about the solubility of the liquid. What's the liquid? It's blood. Be more specific. Not just blood, red blood cells. Not just red blood cells, hemoglobin. That's what we're really talking about here. We're talking about the solubility of hemoglobin. So when I say increase, or when I say decrease affinity, we're saying less soluble. Increase affinity, more soluble. Affinity just means to like. I'm almost done, by the way. I think I got like one more slide. I'm going to skip this slide. I might try to address it in the videos that I made. Carbon dioxide. This is the last slide. Let me make sure. This is the last slide. How does carbon dioxide get around the body? We know how oxygen does. Oxygen uses primarily hemoglobin. Carbon dioxide, I made a typo here. I already see it. What I meant to write here was about 7, I probably meant to say 7.5%. Only about 7 to 8% of carbon dioxide is dissolved in your plasma. Most of it, go to this last one down here, they become bicarbonate ions. Don't stress yourself out about this thing I wrote at the bottom, especially if you didn't take chemistry. But why did I put it then? I just want you to get like an idea of a couple things. One, see how it says HCO3 negative? That's bicarbonate. It's like sodium bicarbonate. You'll hear that word a lot because they use it to make things less acidic. It's an antacid. Your body makes it, like your kidneys make it. They'll inject it into you. So I'll give you an example. When you give somebody epinephrine, what's that going to do? It's going to make the heart beat a lot faster. They're making more ATP. So when you're making more ATP and stuff, you're making more carbon dioxide because you're using up oxygen to make ATP. So the more oxygen you use, the more carbon dioxide, which is a waste product. So that's building up. Giving somebody epi, like a lot of epi, is going to build up carbon dioxide in their body, which means they're more acidic. So every now and then, you got to like push bicarbonate into their blood too, to buffer the acidity of their blood. But your body also makes it, right? It uses it as a, your body can buffer its own pH. But anyway, so just recognize this as bicarbonate. So bicarbonate, so carbon dioxide is attached to the water in your blood, and it forms something called a bicarbonate ion. And then later on, it can break back up. So carbon dioxide attaches like to water, and it forms like this other compound. And then when it gets transported through your body, later on, the carbon dioxide will dissociate or break back up. So 70% or so is transported as bicarbonate ions. About 23% attaches to different proteins like hemoglobin. So some of it does grab onto hemoglobin. So we call those carbamino compounds. If you remember proteins, I don't know if you do, but there's like two sides of them, of an amino acid. One's called an amino group, one's called a carboxyl group. Anyway, they grab onto the amino end of the amino acid. And it's fine if you don't remember it. You could just remember carbamino compounds. Most of it bicarbonate ions. 7.5% or something like that. I don't care about the exact percents, around. It's dissolved in your blood plasma. So carbon dioxide actually uses 3 different ways to move through your body. Done. Any questions? Oh, we don't want to see that again. I'm going to stop recording. You guys can ask your questions, but I'm going to stop recording. Stop.